yang paling besar.
So I'm really thrilled to be able to sort of bring together some of the things that Helen and Kabe brought up with regard to disasters and conflicts and war, and really sort of present some of the work around real implementation, real world implementation, right through the midst of what I call, conflicts or disruptors, and specifically the COVID-19 pandemic, and then moving into war. And one of the things that Donna has talked about is, these issues around sustainability and active implementation. I think if I had the theme for this, the active involvement of implementation is the only reason why Ukraine is still implementing HIV prevention today. And I'm going to walk you through some of the process for doing that. And I'm going to sort of use the implementation lens to sort of review the scaling up of opioid agonist therapies, that is for the prevention of HIV. And then you've had a presentation by Dr. Madden in terms of the NIATEX model, and so we're going to sort of now take this blended strategy. So we've got a strategy on top of an evidence-based practice in order to do this work, and then really talk about how these disruptions, so now moving to the Lego model that Donna talked about, is how do you modify and change. And we didn't have that mathematical and quantitative thing at the time, but I will say that in terms of us thinking through some of the analyses, Donna has given us some good ideas about how to sort of think about this work. I just want to sort of talk about, this has been 20 years of research with a huge team from Yale and Ukraine and some modeling from our colleagues at Bristol University and working with research NGOs and stuff like that. So this work really requires a rainbow coalition. Ika talked about community involvement, and there's a fair amount of that happens. These are some of my really good colleagues from Ukraine, from 2 different agencies. These are a number of my colleagues at Yale, Julia Rozanova and Sheila Shenoy, who's also working here, who've done this work. And then Lynn Madden has been sort of my muse, hooked at the hip, if you will. I think we've been in more countries together than most other people who have been. And then an array of pre-docs, postdocs, and others who have been sort of doing this work. This is a slide that is said over and over again. The thing that we're doing is we're scaling up HIV prevention, opioid agonist therapies. How we're doing it is using sort of NIATEX. And what we're really looking at, and you can have long-term consequences, does it actually prevent HIV infections? But what we're looking at is actual census, the number of people on treatment, because the WHO has set really ambitious targets that at least 20% of people who inject opioids should be on opioid agonist therapies to just flatten out the epidemic. And if you want to start to control it, you have to actually get to 40%. And as you can see that, except for in Western Europe, most countries have not gotten anywhere near there. And so these are the sorts of things that we bring to the table with regard to doing this work. And then of course, you'll hear me say over and over again and others, can we do this better, faster, and cheaper as we go along? We use the Integrated Promoting Action on Research and Health Services, the IPARIS framework. We haven't talked a lot about that, but really the context is important. And I have to tell you that when we look across all of the 109 or so frameworks, context is in every part of those. What we use is one of the key elements in NIATEX, which is facilitation, which is a very active process as part of this. The innovation, which is not so great in Ukraine when we first started, is the evidence-based practice. Neither providers nor patients really thought this was any good. It was the treatment of last resort. And how does that play itself out on, sort of recipients? So we haven't talked a lot about treatment of addiction as an HIV prevention tool, but opioid agonist therapy with methadone and buprenorphine is truly one of the most effective and cost-effective strategies where people who inject drugs. We have other things that are within our sort of toolbox in addition to OAT. But remember that if you get people with HIV onto opioid agonist therapies, it also improves each step of the HIV treatment cascade. But there are other sorts of interventions that are available, and we're going to focus on this particular related area. The evidence is irrefutable, although within the region region of Eastern Europe and Central Asia. They have it didn't get invented here, so we don't believe it. So it's a problem. So one, you have to sort of sell the innovation or the evidence-based practice. And one of the things that is true is, and I think Donna talked about this, when you get enough numbers of people to do this, Linda said this over and over again, it changes the Rogers diffusion of innovation so that it's not just an early adopter, but it actually is other people who are taking off with regard to this. And with regard to the evidence, this is a mathematical modeling study. And if you take a look at sort of low coverage, medium coverage, and high coverage, on the left-hand side for opioid agonist therapies, and then the other treatment is prevention, HIV treatment is prevention that Sten has been talking about, sort of low antiretroviral coverage, moderate, and medium, and then combining them at various different levels. You can see that you're scaling up methadone in epidemics that are concentrated among people who inject drugs is going to reduce the most HIV infections, all right? So that's the first thing to do, even relative to high antiretroviral coverage. And when you combine them, of course, it's not surprising that we do combine interventions because we often will have a patchwork quilt work of interventions that we're layering out into the community. But if you combine them, you actually see on the far right-hand side, you get the greatest reduction in new HIV infections. But because methadone costs pennies per day, and antiretroviral therapy is in the thousands per year, that is, you actually see that the cost of reducing one infection is 4 times lower than it is for antiretroviral therapy coverage, and there are benefits to society. And if you're a low or middle income country, which Ukraine is, it is certainly one of the things that you try to use something that is more cost effective in order to get the most bang for your buck. So my introduction to Ukraine actually preceded this implementation project, and it really sort of told me that these were a group of folks who were ready to be different than Russia, in which opioid agonist therapies are still completely banned. I first showed up in November of 2004. I stayed at a hotel. These are photographs of the Orange Revolution, and they were clearly trying to pave a different pathway, which they introduced that same year, which was buprenorphine, which actually Yale was actually hired to help with that sort of introduction process. But the process over time, so we talk about that 17 years, and it was much, much longer than that. We introduced buprenorphine over the period of the next 5 to 6 years. We got 700 patients on treatment. This is among 360,000 people who inject drugs in the country. It was too expensive. The government couldn't afford it. I started methadone, which was much cheaper. You see a sort of an increase that's happening. This is for about the 360,000 people who were estimated to have HIV, a similar number who were estimated to inject drugs. 82% of them are injecting opioids. And the coverage at that particular time point when we began to get started was about 2.7%. So we had a long ways to go. And we started working it with the idea that every step where you increase patients is moving in the right direction, right? They have a volatile HIV epidemic. They have the sort of one of the highest HIV prevalences in all of Europe. It's concentrated in people who inject drugs. There has been a transition, like in Malaysia, more towards sexual transmission. But methadone is very highly regulated with very rigid systems and laws that were really important, that were restricting some of the access sorts of issues. And so one of the things that we knew is it wasn't money that was getting in the way. They had enough money, and they had targeted for 30,000 people to be on opioid agonist therapy by 2015. We were in 2011-12, and they said, how can you help us? We wrote the first NIH grant. We got funded around 2014 to begin to do this sort of work. And what we did, that was really a learning lesson, and Donna and I were having a conversation about this, is we actually did qualitative interviews with 199 people who inject drugs. It took us years to analyze the transcripts, and we were able to really deal with this. But one of the things that was really interesting is one of the first nominal group techniques that we did in 1 hour gave us pretty similar answers, but we were able to really identify what the patient level or the individual level issues were, what were the interpersonal relationships with the clinicians, what did they think about it and their families, We were able to sort of see what were the organizational constraints that were, and the things that were available that were happening. What was happening with the community? This was one of the most disdained sort of treatments. We did some work with machine learning to try to look at memes towards methadone that are mostly generated out of Russia, really a universally negative sort of perception. And then we reviewed the legal landscape and the policies in order to understand what was getting in the way. And when we conducted a sort of a quick assessment using item response theory among a group of several hundred people who inject drugs, in terms of looking at what's getting in the way of getting onto treatment, we really found that there were treatment attitudes. This is not an effective therapy, it's going to harm me. Program logistics and entry challenges, things that are fixable by changing the way that you do your work, whether it was an appropriate treatment or not, and stigma. And we sort of have these conversations, and in places where drugs are criminalized, stigma always comes out. But when you use the item response theory, 86% of the barriers fell into two different categories, and the stigma sort of fell out of that as being sort of major priorities, really saying that process improvement, which Niatex was chosen as the bundle of implementation strategies, was the right fit for the types of things that you needed to sort of work on. We were getting through some of this work, and then we were interrupted, at least at first, with the first invasion. These are my photographs right from the downtown area. These are Molotov cocktails that are right in the central square, one of the places that we've grown to really adore. That tall monument is their independence monument, and they had a fierce sense of independence. And this is when we were able to begin to do our work. And at that time point, 800 people had been dropped from methadone as Ukraine had annexed Crimea. So there was a sort of a call that they were going to save the people of their country. And I want to sort of bring that forward when we talk about the most current invasion, because you saw that same sort of spirit sort of move through the process. We used part of the elements of Niatex, this sort of bundle of implementation strategies, where we had facilitation. Remember the dose, it was once a month. The target was the chief narcologist. Now I will say that one of the lessons is that you do change what you do. So Lego would have sort of fit in very nicely, because we started out and we got a whole group of people in the community with NGOs who were going to do the implementation, and we changed what we did because we realized that we needed executive sponsorship. So we chose the chief addiction treatment doctor who oversaw all of the clinics in their region to be the change leader and would actually have the change projects that would happen. So we did change our sort of target very early on when we weren't really getting much movement. Dr. Madden went through the principles of Niatex, including the 5 key parts of that was used consistently and over again. We set an aim, and it was very simple. Increase the number of patients who were on opioid agonist therapies, and then they had change projects that focused on bringing new patients into treatment or sort of keeping them from dropping out, and they could choose what they wanted, because some sites were doing really well at bringing in new patients. Others were keeping on to everything, but they could not add a single patient. And so the kinds of implementation and change projects that you would do would differ from site to site. We used the rules of Niatex. Basically, the rules were you don't get any extra money. So we always cry, well, if we had money to do this, we had money to do that. We had to do something with what we had there. We did get the executive sponsorship and our change leaders, and we did all of these various sorts of tools to begin sort of the project at work. And we came together 2 to 3 times per year as part of a learning collaborative, so that the changes that we're working at each site, that people learn from each other. And one of the things that I think was sort of a takeaway from this is that these people became very cohesive. They became learners and teachers of each other, and they got themselves on these call networks, and they created all of this within a country that had no support. So if you think about people who inject drugs as being some of the folks that society doesn't like, among doctors, being the addiction treatment specialist was also the bottom of the bucket. So they created some strength and some coalition, which we began to measure as maybe perhaps this might be part of the secret sauce of why our bundle of implementation strategies work. So we come in when Crimea was annexed, we use our qualitative research with the barriers to change the regulations. This is a disruption. Our consultation with Donna said use an interrupted time series, and so we did that. And so after we had identified these barriers, we took a look at what happened, and we began to recognize a couple of other things. So Niatex had been used only in high-income settings. People said, why would we do anything more? This is ridiculous. So we created some stimulus opportunities where they would, if they would achieve scale up. We also used lessons where people would learn from outside of the country because they only knew what they knew. So we had learning sessions where we would bring people to the US, and we had a couple of visits. And we looked at all of these various different factors. Did you show up at the collaborative learning meeting, okay? Where the stimulus lectures were given and all of these other sorts of things that were built into or baked into the activities in order to come up with a profile of whether you were engaged, whether you were collaborated. We used some scales to measure collaboration between individuals. And then we had these sort of site visits, and then we created challenges. So behavioral economics. If you can scale up by 20%, you will earn it was really a small amount of money, but it was symbolic, and it was actually enough, $500 was meaningful. These folks made, in general, about $200 to $250 a month. So getting a bonus over a year's worth of a challenge was actually quite significant. And so, we just sort of use simple dynamics. This is one of the things that I think even my 10-year-old can be able to get. You need to bring people in, you need to put the stopper in the tub, and your census will go up. And so it was pretty basic. And in implementation research, I would say when you can keep it basic, it makes it much, much easier. And we had administrative data from the CIREX database, which allowed us to take a look at every single person who had touched the system who was in the governmental programs. And so what we did was we were able to sort of take a look at what was the slope of the scale-up, and this was, at the time whenever we actually had been doing Niatex, so we had gone up a little bit, and then Order 200 was changed with the work that we were doing in our implementation, and that coalition of physicians helped guide the change in the government in terms of what was needed. And that particular change in Order 200 was actually included a number of different things. And that Order 200 change basically said that patients can go from having to be observed every single day to being allowed to get take-home dosing if they had 6 months of sobriety. And that was measured by, kind of monthly urine drug testing. And the physicians were allowed to actually allow them to sort of move to that. Now, if you think about it, we heard of some studies that were going on where you were looking at the costing of patients having to come in for DOT, for tuberculosis every single day, and the cost associated with doing that. But there's also, that's demands on patients. They can't go to work. It gets in the way of work. But there's also demands on clinicians. And one of the things that you can see is that as we began to do some of this work and put in, basically challenges, some behavioral economics, you can see that places responded very differently, recognizing that you do not get a uniform sort of change that happens as part of your implementation because they're implementing sort of differently. So we had actually one site that scaled up by 71%. We began to call him the champion, and he invited us to his house and to swim at his lake, and we did all of that. But we had 7 other sites who did meet the 20% scale up, so 8 out of the 25 sites. We had others who still made some progress, and then of course we had some that just didn't do a whole lot, and then of course Crimea did not, they lost all of their 800 patients at that time. So anyway, they were able to take home dosing. They removed another really nasty part of their legislation, which meant that a person had to go through detox twice in a hospital. I mean, who's going to come into a hospital and get watched to get sick? That was really important. They also allowed for the first time, and I'm not going to spend a lot of time with it until later, but they allowed for the first time for the medication to be treated in private clinics. We had done a study with a willingness to pay. It had a threshold in it with which they would pay. And there were a lot of people who did not want to be registered, who were willing to pay out of pocket. Now, I will say that currently 1/3 of all of the patients on opioid agonist therapies in Ukraine today are on treatment at a private clinic. So this alternative economy occurs when there are constraints on the current system of care. We recognize that places, sort of were very different at baseline. They have a highly vertical system with the chief narcologist or the chief addiction treatment specialist who sort of was the executive sponsor who handed things down. By the way, for those of you who use word processing, if you try to type in the word narcologist, it gets moved over with a spell check to necrologist. Not a really nice thought, but it was kind of how people sort of saw things at the time. There was a not invented here. There was a mistrust of ideas that were coming in from the West. We did a number of different things. We gave them tools. We gave them stimulus lectures as part of this. That's training and education that sort of happens there on a number of different things. And they were targeted to really sort of promote the implementation scale up. And then we actually measured collaboration climate using a standardized scale. And then we did an assessment of risk takers. And the risk takers were those individuals who basically every shiny object, they were willing to go on to it. Oh, I want to try this, and I want to try this, and I want to try that. And they would do those sorts of things, but they wouldn't really sustain the things that they were learning afterwards. And we were able to do sort of a data reduction strategy, looking at whether the chief narcologist, basically went to these events. In other words, were they learning sort of regularly? How they scored on the collaboration climate scale, whether they were independent risk takers, and whether they got learning ideas from outside the organization by trip 1 and trip 2. And they really fell into 3 different groups, and we get to call them what we want. Our team initially called the delayed adopters laggards. I didn't think that was really the kind of term that I wanted to call them. But essentially, they had really sort of low leadership in terms of showing up for things. Their collaboration climate was really in the middle range. Their independent risk-taking was really low. I'm not going to do anything that's novel and new. All the way to the independent operators who slightly differed. They did actually met high levels on the independent risk-taking scale, but they were really not quite as present in terms of all of the meetings because they said they knew everything and how to do it, they did it. And then of course we have the engaged collaborators, and they roughly broke into 3 different groups. And what's interesting, whenever you sort of combine the new patients coming in, the patients dropping out, and what happens in the census, you can begin to move forward and see what happens and what contributes to this slope. So what we're going to do in the next slide is we're going to break down this slope, this purple line, in terms of what happens based upon whether you're in one of these 3 groups. And so one of the things that you can see is that in the orange, the engaged collaborators were the ones who were actually enrolling more new patients. They were opening up the front door in order to bring patients in. The independent operators probably represented what would mostly happen if you didn't do anything. We know that there are always people who do better than others, and so they were probably representing a subset of the status quo. And then of course our delayed adopters were the ones in green. They just did not enroll. But what was important is that all of the different groups did actually increase, but they increased at different rates. Now that's the first part of coming into the census, if you will. And then of course, the second question was, did they keep the patients that they had in treatment by, let's say, doing optimal dosing, which is one of the things that we coach them for, how to open up the door, how to change your procedures so that people can get treatment on the same day. And what you can see is in terms of retention, this is actually by dropout. So the highest rate of dropout was by the individuals who were the independent operators. So they brought them in, much faster than the other group, but they didn't actually keep them. So they weren't sustaining the gains. That was really important. But the lowest amount of dropout is in the engaged collaborators, which meant that they were contributing the most to the scale-up. But the secondary thing that we learned about that is that just touching the system is really important. So getting a new patient into treatment, because because they developed these standardized protocols that was part of their change project to test everybody at the door as they came in. And this is from an independent survey, not from the NIATEX database, but is 558 people with HIV out of 2,000 people that we sort of recruited as a sort of a national survey. And we found that the detection rate for HIV was hitting the 95 goals, at least in terms of getting onto treatment if you were on opioid agonist therapy. But you can see that just touching the system jump-started it, even if you dropped out of treatment, which is in the purple bar, and the group who is in the gold or the orange bar is the group of people who had never been on opioid agonist therapy, really suggesting that that is a really important secondary goal that we had not anticipated right up front. But if you look at every step of the care, a number of the patients stuck. They stuck to getting the test, they stuck to getting treated, and to doing well on treatment, being adherent over time, which was really one of the secondary benefits, even if they didn't stay on sort of therapy. So let's move to the next disruption. So the first disruption was changing the regulations. The next one is COVID-19, and of course everybody can remember this from not that long ago in terms of the fact that we had to do things differently by force majeure. We had no choice but to change the way that we delivered. And I will say that in many countries they just quit enrolling patients. Well, we can't see them, we have to do it in person, we have all of these sorts of things. Not Ukraine. Ukraine did something very, very different. And notice how that slope actually went up. Now what contributed to that? We actually, so Donna would say, you changed what you did. So this is a Lego, learn as you go, right? We had clinicians who were scared to death that they were told as part of the guidance that they should move as many patients to take-home dosing as possible. Their previous regulations were 6 months of directly observed therapy. And they said, these people are going to overdose, they're going to die, we're really scared, they're going to divert, they're going to do all kinds of awful things. And I said, let's measure that. Let's see what happens as part of that. And so we changed the coaching. How do you assess people? How do you move people to faster doses so that they feel better and do much, much better? And you move them to take-home dosing so that you can keep your staff safe and you can keep your patients safe, especially when there were lockdowns and being able to travel was hazardous to them, oftentimes on public transportation. And one of the early things that we learned that during the first 6 months by changing and giving stimulus lectures and helping move them in the right direction is they went from having 53% of their patients on take-home dosing to 84%. So that's a 30% transfer of patients who were getting take-home dosing much earlier than they would have otherwise. And what was really interesting about that is that it didn't actually, at least in the short run, change the mortality. It went slightly down, but it was not a significant difference. But one of the things that it did is if you think about what gets in the way of implementation for both providers and for patients, is coming to treatment every single day is a demand. You have to get there, you have to wait, you may be subjected to stigma, and then you go home. But you're supposed to take care of your family, and you're supposed to work, and you're supposed to do all kinds of other things. So it changes the demands, not only for patients who have to do all of that, but for providers who have to sit there and watch everybody take a dose of medication and do all of these other sorts of things. Now, what does that mean? If you move 30% of the patients to take-home dosing, it reduced on average 1 million visits over the course of a year. And that 1 million visits, even if you conservatively said that it's 5 minutes of their time, that translates to 86,000 hours of time. What does that mean? I have 86,000 hours of time that I can now devote to calling up the patient and checking in on them because I'm afraid they're going to overdose or they're stressed out. Or I can call them up and have them, come in if they're getting into problem. I can counsel them. You can do this, but you can also let new patients into the door because your doors are open much wider at that particular time point. Now, as a test of this, we did a sort of a 2-cohort study where we looked at individuals in the 1 year before the COVID guidance and then starting with the COVID guidance in the middle of March, what happened in the year. So we have 2 parallel, non-contemporaneous cohorts of individuals, and we looked at a couple of things. So we have the standard enrollment period is 6 months and at least 6 months of observation to see what happens. And as you can see that in terms of newly enrolling patients on methadone and moving to take-home dosing, you have earlier take-home dosing. So there were some people who would come back into treatment and they would move a little bit more quickly. But essentially over a 3-fold increase in early take-home dosing, even in the first quarter, because they had gotten them up to sort of a reasonable dose, and that sort of equalized by the time that you get to the end of the observation period. It just meant that we were doing things much, much faster. And then in terms of the dosing, we actually found that the doses that they got also were higher, meeting an optimal dose. And what did that translate to? The rate of increase during the COVID period was 236 new patients enrolled per month, relative to 284 in the previous year. And if you look at things like retention on treatment, it was significantly different over the course of the entire year of each cohort. And the transition to take-home dosing was the single biggest predictor that individuals were going to be retained, portending a 30% difference in retention. So think about this. If you're able to go get your medicine once a week or once every 10 days, and if you take your medication, you have less demands, you have less reasons that are going to get in the way of you taking your medications, all right? Now, to be honest, these clinicians were desperately afraid that their patients were going to overdose and die. Just much like for HIV, they were afraid that their patients were going to get, counseling adherence, and they weren't going to take their medications. Guess what? That's not what happened in the world with HIV, and it didn't happen that with opioid agonist therapy. The factors that did sort of portend that they would stay on to treatment was that they actually got them up to an optimal dose of 90 milligrams or more. They were HIV negative because they were letting more people into treatment, and if they were new to opioid agonist therapies. And we looked at this between the two, we compared the two time periods, and there was no difference in terms of the mortality rate. So we did it faster, we did it better, and we did not do any harm. So that was the way to sort of analyze and think about these sorts of data. Now we're going to move to the war. Once again, we had sort of kind of calmed down a little bit. We went back to our monthly coaching calls, and we thought all was well. But we began to think about what's going to happen as the war broke out. I know that Lynn and I lost a lot of sleep. I got a call in the middle of the night saying that this had happened. I knew it was coming because the ambassador had really sort of let me know to get my graduate students out of the country about a week before. And one of the things that you can see is in terms of the coverage, once again, the regions of the country at the time, we had already moved from 2.7% coverage to 6% coverage, by the time that we got to the outbreak of the war, with various different levels that were sort of, scaling up opioid agonist therapies. And what happened then was they said, all right, we want you to let as many people as possible. They were already at 82%. Let as many people. They did move to 93%. During the early part of the invasion. Many patients dropped out of treatment early on because they moved, they were scared, or any of those sorts of things that happened. So once again, we lost about 800 patients right on the very first couple of days. But what happened was the lessons that they had learned and the coaching skills that we used again over that time period meant that they hopped back up on the horse, got into the saddle, and they continued to scale up. And what is really important from a conflict perspective is they had the support of a government to say that this was an important thing to do, all right? And so there was executive sponsorship. They said that they were committed. NGOs did amazing things like drive-through barricades. They quit using their armored vehicles to go into these regions to deliver medication. They started sharing medication, which was not allowed. So they did things that were not readily allowable. But then they changed the policies in order to protect their staff so that it would be allowed later on. So let's just take a look at this. This is our group having our weekly Zoom calls, figuring out what's going well, what could work better, how do we sort of overcome sort of challenges. This was a regular base, and I sort of see these folks as my heroes today. But we dealt with a number of implementation sort of challenges. Supply chains got blocked off, and in regions that became occupied, they were shut off. And we know that Russia bans it completely, so if Russia took a region, it meant that all patients went off of methadone immediately. And from Crimea, we learned that when those 800 patients came out, 10% of them died within 6 months due to suicide or overdose. So we know that the consequences of stopping this medication are profound. Because of the disruptions, not only in the ability to get medication where it was, there were also disruptions in terms of access to heroin. And so new substances, mostly stimulants, started coming into that. There were internally displaced persons that were moving like crazy. Women could actually get out of the country. Men of a certain age group were unable to leave the country during that time period. There were sort of staffing having to think about how to prioritize their local needs. They knew how much medication they had. They had to make decisions about whether they were going to start to taper people's dose slowly, and we coached against that. Whether they would take in new patients, whether they were going to take people who were newly displaced. And remember, there were 10,000 patients in the private clinics, and the pharmacies shut down overnight. So those folks had to have a way to get into treatment. We know that early on, 20 sites were either bombed or shut down almost immediately in the Donbas region. The Ministry of Health said, if you're in a conflict area where your patients is too dangerous for them to be able to get from point A to point B to get their medications, you can give them as much as 30 days worth of medication. There was various amounts of medication that was dispensed. They had to make decisions about how much medication to give people if they said we're going to move to a safer part of the country. And there were all of these private clinics that had a lot of patients who needed to get into treatment. But there was also, on the other hand, patients who were afraid to travel, or they had parents who could not travel, so they could not leave. They created online message boards. They created networks, Viber and WhatsApp messaging groups to say, the sirens are not supposed to go off between 11 and 3. Please show up for medication if it's your turn today. And then they were sort of these closed social media things. And they used crowdsourcing to get the information out about how to get onto treatment if you wanted. And in a different paper, we sort of looked at the way that migration happened from what we would call the occupied region on the far right-hand side, and then to the sort of kind of more close movements within the region. This is not people on OAT. This is just people that were happening in the country. Remember, of a country of 45 million people, 9 million people were displaced either to Western Europe or internally within their country. This is a lot of people who were moving, but it was less so for the patients on methadone. And so you can see that people either moved close by or they moved remotely, depending on their resources, their connections, and other sorts of things. And remember that the early invasion was from the east, on the far right-hand side, and from the north, in Russia and Belarus, as they crossed over to the line. So these were regions that were getting directly shelled. Now, I will say that we most recently have begun to rethink about how conflict causes interruptions in HIV prevention. So one of the things that you can see is we have this Cyrex database that we can look at. And we looked at basically the ability to enroll new patients. That early bump was patients who sort of were coming from the private clinics and moving into treatment. And we also had dropout because places were being occupied and people were moving. And these are the number of internally displaced people in the green. And we're going to do some analyses based upon these sorts of numbers of entry and dropout. And so our first quick and dirty look at how do you sort of characterize what's happening to people and what might be contributing to dropout. So we just use one data source or two data sources to really call something a political violence event. Now, the granularity of that was not enough, and so we ended up taking it further. In the red, this is the area that was completely occupied. The blue dots are the political violence events, and then the little bubbles, the white bubbles, are where the 252 sites are from, around the country, and the yellow line on the north is an area of invasion that was then pushed back. So what we did was we used some different methodologies from the conflict world, and this is the stuff that Kaveh could probably speak very eloquently about, but we decided to cluster the regions into categories, and we expanded by using multiple different databases, whether there was an air raid, whether there was an explosion, whether there was an artillery threat, and the percentage of internally displaced persons in order to create a heuristic based upon risk, all right? We used the Cyrex database, which has every patient detail that you can imagine, their dose, whether they're on take-home dosing, their date of starting, demographic information, etc. And then we looked at people who ended up getting relocated even within their same region, that is, they changed the clinic, or they had to leave their region to take a look at that. And then we applied longitudinal frailty survival models in order to look at changes that occurred. And what you can see here is we categorize places based upon explosions, air raids, and artillery threats as part of that. And you can see that we were able to sort of create some differences. And so we said, what's happening in terms of dropout, depending upon some of these conflict variables? And so what you can see here is that we have got the frontline region, which sort of came out based upon this as part of our data reduction strategy. That happens, that's mostly right near where the occupied regions are. We have the targeted regions, which is where they weren't right at the conflict, but they were certainly having a lot of bad stuff happening in there. You can imagine the threats of a siren every 2 hours is a really important sort of conflict. And then we looked at what was happening remotely. There were still some things going on, some bomb threats and things like that, but it was much, much quieter and safer, and people were living mostly sort of normally. And so if you can sort of go from the occupied all the way to the remote regions, we looked at how people moved. I call this modern art, but it's really these little sort of lines go from whether you move between a targeted region or you were permanently dropped out on the bottom on the green. And it showed the movement because we were able to put this into the model and do some predictors of, or I should say associations with treatment discontinuation. So if you were in a targeted region, so that's the middle area that's not the remote region, the safest region, you were 30% more likely to drop out. But if you were in a frontline region, that is closer to the mess, if you will, versus the rate, it goes up to 7 times higher, which is a very similar number that you see if you happen to be an internally displaced person, either from a remote or a targeted region. And then if you were in a frontline region, so right up next to where the occupied region occurred, versus the remote region, you were 17 times more likely to drop out from therapy. We saw some significant differences also depending upon how well they were managing their disease by having them on optimal dosing and take-home dosing. And we did see a higher dropout for women, but I think that that's because women were able to leave the country, and that is probably the explanation for that. And then, of course, unfortunately, people with HIV were more likely to drop out, and I'm not sure why that is, but that does not portend well, because when you drop out, you have a higher likelihood not to control your medications. We published a number of different articles looking at some innovations where the private clinics began to work with some of the public clinics to make sure that people did not drop out. That had never happened before, and I can tell you there was incredible animosity from the governmental doctors versus these new clinics that were taking away their business, but they came together during this particular time of crisis, and then really to be able to sort of delineate some of the changes. And I will say that our PhD students and our postdocs from Ukraine were all part of doing this sort of incredibly hard work that they were interested in. And then really early on in the epidemic, I was able to present to the United Nations on International Women's Day about an update about the conflict. And I was talking by Zoom with a number of people in the field, and these 3 women sent me this photograph that they said, we would like for you to share with the rest of the world. And these are social workers, and they call them harm reduction sites, but they were treatment programs. And the woman on the bottom basically has a sign that says, opioid agonist therapies equals life. The second one, basically said, we remember Crimea, We do not want that to happen again. We're going to change this as the resilience of the people on the front lines. And we've talked about the patients, the people on the front line who are doing the actual work, and then, of course, continuation without interruptions. They were committed to making sure that their patients got treated. And then I'll just leave this with, from the Ukrainian language, Slava Ukraini, and then the response from you all should be Goroyam Slava, which means glory to our heroes. Thank you very much.
Thank you very much, Prof. Altice. That was really enlightening.